Welcome everybody to July's Cancer Wellness Center Staff Chat. My name is Priscilla Andrews. I'm the clinical manager with the Cancer Wellness Center. If you're joining us for the first time, the Staff Chat series was designed as a way for the Cancer Wellness Center community and the community at large to hear conversations between professionals talking about topics, issues, concerns that are of interest to the cancer community. And I am so pleased today to have two physicians from NorthShore University HealthSystem, Dr. Bogdanovich and Dr. Brockstein. Thank you so much for taking time out of what I am certain is a busy schedule to be here with us today.
Thanks.
Yeah. And
thank you.
Today we'll be talking about cancer screenings and surveillance, which I know is always the topic of interest to patients, whether they're in treatment or post-treatment, certainly also to their family members, also to the community at large. But before we jump into that, I always like to check in with the people joining me. I think it's so helpful to find out a little bit about, what drew you guys to medicine, maybe medicine in general or to your particular specialty area.
Nicole, do you want to go first? You want me to go?
You can go first.
Okay, sure. Mine was kind of roundabout. I didn't really have initially a burning desire to be a physician. I was a mechanical engineer as an undergraduate student, and then as I began doing that, I wanted to apply that to some kind of real life needs, and I sought out bioengineering. This was in the early 1980s, and that really didn't exist. Wasn't really very well developed as a field. Couldn't find mentors or a way to kind of do that where I was at University of Illinois. So I decided to finish my degree and go to med school, and I was going to apply what I did to orthopedics, very mechanical. Decided I liked the kind of holistic part of the patient, so decided to do internal medicine, and I was going to be a cardiologist. The heart is a pump, and that would fit with my mechanical engineering background. But then as I completed my training in residency, I really kind of fell in love with the cancer patient and the cancer field, which really kind of combines, a lot of great biology with some real needs, as well as some, really unique human interactions and psychology. So that's how I found my way to what I'm doing.
Oh, I love that story just because it just illustrates how things can evolve and change and being open to that transition over time. Thanks so much. I didn't know any of that, so I appreciate that, Dr. Brockstein.
Thanks, Priscilla.
Yeah, Dr. Bogdanovich?
I also have a roundabout kind of way. I used to teach chemistry in Chicago Public Schools in high school, and that's sort of what medicine sort of was always of an interest, but really that solidified it was seeing the disparities, the health disparities within my students and their families. And so I went into family medicine because there's more like advocacy involved, prevention, and treating the whole person. And I had also specialized within adolescent medicines, which I got to be able to do as part of family medicine.
Wow, that's great. You guys both had like a previous life at some point before medicine, it sounds like. Yeah. Well, thank you so much for that. And, I realized as I introduced your names, I didn't really introduce your positions. So do you guys want to take just a short time to just explain your role within NorthShore?
Sure. I'm a medical oncologist, meaning that I treat cancer patients, not the surgical end or radiation, but kind of the overall care, diagnostics and care of the patient, including any medicines, chemotherapy, et cetera, really kind of from beginning and all the way through. My specialty areas are head and neck cancer, melanoma, and sarcoma. I've been at NorthShore since 1999 for 22 years. And for the last 13, I've been the head of the Division of Hematology Oncology and the director of the Kellogg Cancer Centers.
Busy guy. Dr. Bogdanovich?
Well, this is my first year at NorthShore. I'm a family medicine physician here, just general family medicine, so cradle to elderly patients. And just seeing the whole gamut, focusing a lot on prevention too.
Right. There must be a lot that comes through your door, I would guess. And a lot of people, I would imagine, unfortunately, that you end up having to send to Dr. Brockstein's way after catching something. You're kind of that front line, I would imagine. Yeah. Well, thank you both again for being here. So kind of want to turn our attention, here we are today to talk about surveillance and screenings. And I do want to just take a moment, to just acknowledge we're meeting virtually, which is convenient, but also born out of the COVID-19 pandemic. So just to start with, kind of curious from your perspectives, what changes you've seen over the last 12 to 15 months as far as, the delivery of screening tests, the frequency with which people are coming in, and maybe how that's also changing as we're entering the sort of vaccine phase of the pandemic.
Nicole, you want to go first? You're kind of on the front lines of screening.
Yes.
I kind of get things on the back end.
So the biggest thing that I've seen is people waiting. They're afraid to come in, especially in the beginning stages of the pandemic. And we were seeing things at later stages than we would normally have caught things prior. People are still scared to come in and get their screenings, like the colonoscopy, let's say, but there are some safeguards placed within colonoscopy, even where people get a COVID test prior to the procedure. But definitely we're seeing a lot more people that are afraid to get the screens. Mammography, people have gone 2 years now without mammography. And we're seeing things caught now as at a much later stage.
And I'm just curious, I think, was there a point earlier on where when things were less clear, you may have been suggesting people hold off on coming in for things that weren't medically necessary, but that's not the case now.
Right. And initially we weren't even doing some of these screening procedures unless it was more of an emergent kind of case. It's not really even like screening at that point. It'd be a diagnostic procedure. But at this point, we can go ahead and do the screening procedures.
There's not any limits or restrictions on that at this phase.
Only if people have symptoms such as like upper respiratory symptoms, then we tell them to hold off.
Yeah. And you already mentioned this with the colonoscopy. Are there other, what are the sort of precautionary measures that are in place if people have been reluctant to come in for these tests, but want to be responsible around their screening tests? What can they expect?
General screening questions, asking them if they're symptomatic, if they've traveled or near anybody who's been near anybody who's had COVID. There's the temperature screening, the wearing a mask, and then with the certain procedures, we get the colonoscopy, we get the COVID-19 testing.
Gotcha. And just to distinguish this, if somebody hasn't been in the healthcare system in the last 15, 16 months, even though masks are not required for vaccinated people outside of the healthcare setting, they are still required within the healthcare setting, correct?
We were required even just for our visits.
Yeah.
And I'll add in, a couple of things is, right. So for the first few months, we actually had to, for safety purposes, shut down any unnecessary interactions within the hospital setting. So other than urgent things, COVID care and other things, number one, because of safety and transmission of disease, but number two, a very practical thing is that the hospitals were becoming full and elective procedures and so on, there really wasn't room to do that. In the very beginning, in the first 3 or 4 weeks, that people might remember, it wasn't clear if masks were helpful or not. Could you transmit things through masks? And they actually weren't even available. Like, we had to have limited masks. Like, we didn't wear masks the first couple of weeks. Then when we got them, we had to wear our same mask for as long as it could be worn. And eventually it became very abundant. But even through that, and I work in the cancer center. We have 250 employees. We have hundreds of patient interactions every day. We tracked employee infection, and we tracked all of our patients who became infected. Some of them became infected because they get infected in the community. But when we mapped out when patients any patient that became positive or any staff that became positive, there were no interactions. So we were able to ascertain that throughout the whole COVID, the 15 months of COVID, especially the first 4 months when we tracked each and every case, there wasn't a single case of transmission, despite the fact that we spent, sometimes hours together, patients getting treatments for hours. And the main reason was mask on mask. We wore masks, in healthcare, the patients wore masks. And with that, it's very, very hard to transmit COVID that way. Very hard if you do the other things, keeping your distance and so on. So it is very, very safe. If you go in for a brief mammogram, colonoscopy that takes 20, 30 minutes, you're masked and everybody else is masked, you're not going to catch COVID. All those precautions are in place. And then the screening, as Dr. Bogdanovich pointed out, the screening pulls out the people who might be at risk of transmitting it. And then everybody else is at such low risk of having it. If they're wearing masks and somebody else is wearing masks, it's just really essentially not going to happen.
Take home message, you're not going to get it from your routine doctor's appointment, your routine screening.
Right.
It looks like you've been following that very closely, Dr. Brockstein.
Yes, and I think almost all of us in healthcare would say that, especially during the peaks of the pandemic, I'll speak for myself, but most of my colleagues, we all felt much more comfortable going to the hospital and going to work for 8 or 10 or 12 hours a day than we did like going to the grocery store for 5 minutes.
Yeah.
And it was because people know how to wear the mask, the interactions were right. So it's very safe. It really is.
Yeah. You're not going to see a lot of people with their noses hanging out when they're
Right.
in the hospital, at least not for very long before somebody asks them to pull that up. Yeah.
Right.
The
true.
other question that I noticed a transition myself, but I'm curious like what the policy is as far as having a family member with you, especially for people going in for something like a colonoscopy right now. Can people have somebody with them? Are they still needing to wait in the car? How are you guys handling that?
So I know initially with the colonoscopy and all the different procedures, you could have nobody with you. They would have to wait in the car and then pick you up, when somebody takes you to the door. I'm not exactly sure with the procedure right now, but I know for doctors' visits, we allow a person in with them. So I'm not sure if that's switched over with colonoscopy or mammography and those types of screening procedures as well. Maybe Dr. Brockstein knows.
Yeah, it's been, so all this has been done in a very structured way, following the guidelines, following the numbers and the data, and then the guidelines put in place, or in some cases mandates by Illinois Department of Public Health, Chicago Department of Public Health, Cook County, et cetera. So early on, at the very beginning, very early on, we recognized that to minimize the number of human interactions which could transmit COVID, the only people who could come were the patients, and if they had someone who they had to rely on, they were deaf, they had dementia, et cetera, then they were able to bring someone. That applied in the inpatient setting and the outpatient setting and the screening things. Of course, if someone has colonoscopy, they can't drive, so they need somebody to bring them back and forth, but those people waited in the car. And really, it's just in the last couple of months that things started to open up. In our cancer center, for example, we had no visitors at all. What we did was the patient would come in, and we often really have some important conversations we have to have. So we would get people on the phone or video while the patient was in the room. We'd have their loved ones there, but kind of there virtually. And then recently, last few months ago, we opened it up a bit, and now we've opened it so that people can have one visitor for regular visits and for treatments. In the past, wasn't uncommon for serious illness for 6 people to show up for
Sure.
and to crowd into a room to hear about what was going on, and of course that we still cannot do.
But I can speak from the patient end. I think just the relief that I've witnessed in patients that now can have that person there for the appointment. I think even just having that one person is such a reassurance, especially if you're hearing something difficult or the information is complex, to have that extra set of ears. That's great to know that is there. Just shifting to screening tests now and talking about the general population. Could you guys just speak to right now, what are the general screening test guidelines? What should people be getting? when should they be starting them? How frequently should they be getting them?
I feel like this is what can get confusing for patients because different societies say different things. So with like breast cancer, it could be anywhere between 40 to 50 for mammography. But like I know for my general practice, it's a discussion I have with the patient, but I like to start at 40 and have yearly mammography versus 50 in every other year mammography. So all of those could be within different guidelines of different societies. Another big thing is that colonoscopy has changed to age 45 now for the general population. So that's something that I'm just reinforcing in all my patients, especially in their early 40s. I'm like, okay, remember in a few years now they're like, oh, I thought it's 50. I'm like, nope, it's now 45.
Your number's going to get called early for that, right? Everybody gets a chance to clear out before that 5 years earlier. What about, are there other screening tests that people should have on their radar, whether it be blood tests or other studies?
Yeah, so so as Dr. Bogdanovich was pointing out, there's recommendations are made by through guidelines by different national societies, and sometimes there's kind of overlap of jurisdiction in a way. In other words, there may be 3 different groups making recommendations on, for example, whether to have PSA screening for prostate cancer and when to do it and how often. And the reason they may not line up is we try to base it on the best evidence, actual true data and evidence, but it's really hard to do big population studies of 100,000 people to prove that you should start at this time and that frequency. It may take 20 years to do the study, and then it would take another 20 years to refine that study more. So we have to base it on interpretation of big studies, and that's why, for example, you'll have some of the, speaking of prostate cancer, I wasn't intending to talk about that. There are recommendations, ranging from yearly to never do it, or if you do it, to stop doing it at a certain age, which is common to almost all the cancers. There'll be a starting age, and that matches when your risk starts to go up. You don't want to start screening people when they're 12 years old if their chance of finding something is 1 in 10 million, because you're putting them through a test and false positives, maybe radiation. And likewise, if somebody's, I'm going to take the extreme, if someone's 110 years old and you find cancer, you're not going to be able to treat them for it in most cases. But other things like prostate cancer, if you find it in someone who's, elderly, who's, 88 years old, the likelihood that they'll ever need treatment or die from that is very low. So screening for that means you got to tell them they have cancer, they're worried about it, they may get a lot of biopsies, and they may get unnecessary treatment that may do them harm. So that's why you'll have this range. And then the frequency also, do you get that screening once a year, once every 2 years? That's based on what's right for the patient, so that you're not over screening and over testing. And some of it goes into actual what's right for the populations, healthcare economics. We could do a CAT scan on everybody every day for their whole life, and we would find cancer at the earliest stage. We would do them harm because of radiation, but we would also be spending more than the entire, gross national product. So we would run out of money. So you have to balance what's right for the patient, what's right for populations, where we spend the money. So it comes down to these recommendations. For example, cervical cancer, that went from kind of a yearly thing to when you reach a certain age, if you haven't found any changes, you may never need to screen again because you don't really find anything beyond a certain age.
Yeah.
And even that one, they are debating between 21 and 25 starting it now. So it's, everything's in a state of constant change as we find out more information.
Well, I think it points to the fact that science is an evolving discipline. I mean, just to go back to what you said, Dr. Brockstein, in the early days of the pandemic, we were still gathering information to understand what masks can do. And now we know very clearly what masks can do. And it sounds like it's the same with screening, that as doctors, as scientists get more information, then they make the necessary adjustments to what those recommendations are. And I had no idea, it's new information to me, that the different societies may have different recommendations. So it may be if if a patient is hearing different things, maybe from different doctors, that may account for why one doctor may recommend 40 and another doctor may recommend 45 for a mammogram, for instance.
Correct. And then you got to overlay on that for the individual. If they're higher risk because of genetic factors, family history, other risk factors, things they've been exposed to, that may modify, the boundaries a little bit to starting earlier or later, doing it more or less frequently.
Yeah. Well, that actually leads me to another question that I encounter frequently. Historically, I used to work with the ovarian cancer group that we had here at the center, so I heard it a lot, which is, and not just specific to ovarian cancer, but I think across the board, people who've had cancer being concerned about their children's risk, their siblings' risk, especially if maybe their parents or their grandparents had cancer, or they have a secondary relative like an aunt or uncle. How does that come into play, when there is cancer in the family, as far as these recommendations?
I feel like I'm talking a lot, but it does definitely, we take it into consideration. There's also certain guidelines with that, like let's say colonoscopy, you might say, depending on the age, is it going to be, 10 years prior to when that person got colon cancer, or sometimes we just say 40, or it's dictated by that patient's history.
And then on top of that, I'm sorry, go ahead.
No, please, go ahead, Dr.
I was going to say on top of that, maybe actually trying to, again, get further data. So if the family history is suggestive of a specific genetic predisposition or hereditary predisposition, you've been passed on the genes from, family member to family member, that you may also be predisposed to cancer, then you can, in some cases, test for that cancer. And the most common one that people have probably heard about is the BRCA genes, the BRCA1 and 2 genes. They're really not specific for only breast cancer. That's where they were first identified. So if that family history is there and someone has tested themselves or their family member, implying that they may actually carry that gene, that may change how early you start screening, how frequently, and even how you do it. So for example, somebody who carries the breast cancer, the BRCA gene, a woman may have screening that starts earlier. They may have breast ultrasound and MRI. They may be doing screening every 6 months. There's several different strategies that are proposed, but they also may be followed in a high-risk screening clinic, in addition to their trusted primary care doctor.
Well, and it seems to speak to the importance of making sure that, if you don't have a cancer history, that you're updating your physicians with that family history as it occurs, or making sure that you've communicated that, because it sounds like that's going to play a role in what the recommendations are that follow.
And also something we're doing, at least on the primary care end, is when somebody comes in for a physical, they can fill out a survey. So as part of their questionnaire is whether you have family members that have a certain degree, family member that has different cancers. And then we offer genetic testing panel. And if you say yes, you have a certain degree relative, then we submit that to insurance, versus everybody has the opportunity to pay a nominal fee to get the genetic testing.
Even if the insurance won't cover it.
Correct. And if it's positive, you get a telehealth visit with genetics.
Right. I'll point out, I will own up to, in the past year, my annual appointment with my primary care doctor got canceled because of COVID, and I didn't make one up. So this week I'm going for, it's going to be 2 years. But building on what Dr. Bogdanovich said, so in the meantime, my primary care doctor retired. I got a new one. And so I got the genetic health questionnaire, which I filled out actually last night. I've had some family members who've had cancer, so that kind of flagged me for getting the genetic testing. So it's really it's a great structured way to try to do what you're talking about, Priscilla, which is to identify those people who are at excess risk. And then if you happen to find a hereditary gene, then you actually are empowered to do something about it, which is to screen, to try to identify the cancer early, screen in a different way, talk to other relatives so they could get screened. So really is a nice tool.
I'm curious, I know that some of the people in our audience, maybe many of them are going to be a part of the NorthShore system, but certainly we have people who are within other systems, healthcare systems. So I'm curious what recommendations you would have for a patient if their healthcare provider is not doing that genetic screening, is not looking for that family history. How might they be able to advocate for themselves to make sure they're getting the most robust screening possible?
Yeah, it may or may not, it does take a little bit of self-education, and I guess that's what this is about. So I think if somebody identifies or kind of senses that they have a lot of cancer in their family, that's something that that they can discuss with their primary care doctor, who in most cases will have access to sending somebody to a medical geneticist or ordering the test themselves. In NorthShore, we try to make sure that people who are getting genetic testing in most situations either are first visiting with a medical geneticist or have access, as Nicole pointed out, to getting a very rapid visit with a medical geneticist should they have a test that is positive. There's a lot of direct to consumer things too now, right? So patients have the ability to, get 23andMe tests and things like that. And it's only going to change over the years. The tests that NorthShore is doing that used to cost many, many thousands of dollars. Now it's actually very inexpensive, so it can be done on a mass scale, like was mentioned. And soon it'll be so cheap. Well, I don't know about soon, but at some point it'll be so cheap that, it may take the healthcare system out of the loop, which is great, except that people then have information that they're not sure what to do with, and then they have to return to the healthcare system. But knowledge is a good thing. So finding out in general is a good thing, as long as there's something you can do about it.
Anything to add, Dr. Bogdanovich?
I think that's exactly what I would have said.
What about people who've had cancer? People who are, let's start with people who are in treatment. People who are in treatment, maybe they're coming up on when their annual mammogram or their colonoscopy is due, assuming they don't have a cancer that was related to those screening tests. And maybe that screening test was already delayed because of COVID. What are you guys recommending for those individuals who are in chemotherapy, in radiation, maybe more recently post-surgical?
I guess I'll take the question since I'm treating the people who are, or seeing those people who are actively under treatment. It really depends on the individual. There's a million different scenarios. Generally speaking, if somebody's under active treatment, they're busy with a lot of stuff for a period of time. Screening, it's important to stay on top of screening, but whether you screen now or last week or last month or in the future week or future month, those small differences don't really make a difference. So if somebody's actually really kind of dealing with a lot of issues as they're going through active treatment, you may not want to take somebody, for example, who's getting really tough chemotherapy and have them go through a colon cancer prep, which is already super not fun. So that's something, if you're getting a colonoscopy every 5 or 10 years, and maybe you're going to be delayed 3 months, that's probably fine while you're going.
The importance of communication with your physician and asking questions, and also understanding that when your doctor's making that recommendation, whether it's your family medicine doctor or your oncologist, that they're really looking at all of you and the specifics to your situation and taking that into account, because what may be right for Sally may not be right for Sue.
Very true. Yeah.
I actually, just on that note, I'm just curious, this is riffing a little bit, but I'm curious how you guys have found the accessibility of information, even related to screening tests or surveillance after cancer, or what recommendations are out there, how you've seen that coming into your practice with, people's questions or expectations, or maybe not having realistic expectations.
I think in terms of my practice, when I'm seeing the people once they're in survivorship, I think it's different from patient to patient in terms of what they expect and what they know in terms of guidelines. I happen to have in residency gone through a whole like survivorship training module where we learned about the benefits of various screenings and how certain screenings are more than necessary in patients that have undergone certain treatments. But I don't know if all that, I don't know, I'm sure if they Googled it, there'd be information. I don't know how accurate or what the information would be. That's really speaking to oncology, if there's anything that's put out on your end.
Yeah, I mean, I think general recommendations, again, if you're within a health system, it's very helpful. Our health system, does it in a structured way. You get reminders on your app when you're overdue for vaccination, for colon cancer screening, for pap smear, et cetera. So that's really helpful in the general setting. The same things apply to someone, who's going through cancer treatment or survivorship, because that at least allows people to know that you're due, whether you go through with it at that time or not. That's can refine that decision between, yourself and your physician, your primary care physician or your oncologist. But in terms of, sorting out the recommendations, it's tough. Right before I got on here, I brought up a chart, which is screening recommendations from the United States Task Force on Preventative Services, the USTPFS, I think. They have a very nice chart, which goes through not just cancer screening, but all kinds of preventative services. And it basically says this is the recommendation, and there is really good evidence, not good evidence, or medium evidence. So it takes into account the fact that these recommendations are being made. We want to let you know when it's really something that's really strong evidence, and where maybe it's not as strong evidence, and you still might do the screening or the preventative treatment. But, again, there may be reasons to modify it under certain conditions.
I think it comes back to the point that I made earlier, which is talk to your doctor. I say that so often to the people that I work with is how important it is to be having conversations with your doctor, and especially if you find information on the internet, that you're bringing that up to your doctor to clarify, because what we as lay people may come to understand around something may be very different than what you as physicians are going to be able to recommend and guide us on.
And then, of course, there's the things that everybody talks about, like we were talking about mammography, PSA, PAP, colon cancer screening. But then when I go through all my screening questionnaires and things with my patients, I mean, I might look at lung cancer screening in a smoker, former smoker, that I do on my patients when they reach a certain age, just like a one-time not necessarily, but a low-dose CT scan. And that some of these other screenings might not be as well known to the general population.
Well, that does bring up, I think, a question that comes up, especially with people that have, not breast cancer, not colon cancer, not prostate cancer. I mean, I think those are the three big ones where pretty much everybody knows about those screening tests. But, when you've got somebody where, maybe there's breast cancer in the family and there's also pancreatic cancer in the family, or lung cancer, where people are concerned about an increased risk for those, but there's not a specific general guideline test. Like what does that look like for those patients where there's a family history where there might not be a screening test for it?
Right. So you mentioned pancreas, for example. We don't routinely do screening tests for pancreatic cancer for a whole number of reasons. And yet someone who really has a very, very strong family history, pancreatic cancer, and has a reasonably high chance of getting it, may go through screening tests. And there are clinics for that, or informally they may go through screening tests. So again, that's something that's been harder to prove whether or not, you tend to need tens of thousands of people to screen to sort out whether or not something is beneficial. Pancreas is one that's harder to prove, But if you really have that very strong family history, for example, you may not go, there is no standard screening test, but you might get a periodic test with an ultrasound. You might get a periodic test with a blood test. And what's going to change, and I think it's worth mentioning, and it may even change at North Shore soon, is there, so cancers will shed certain cells into the bloodstream, or even sometimes just DNA from the cancer into the bloodstream. And there's certain recurring or regular abnormalities of DNA, mutations and so on, that we can begin to start to test for in a blood test. So there are screening tests that are developed that are not yet mainstream, but they're being tested, for example, in large studies in England, and we may start participating, where you can get a blood test that may show if you either have a marker for a specific cancer or a marker that you actually have some cancer, maybe not specific. And there's all kinds of pros and cons about doing this. You may find that somebody has DNA showing that they may have cancer, but it's too small to find and you can't even know where to remove it. But the point is that we may be able to take this, Priscilla, to a whole nother thing, which is not just saying, oh, do you have a risk for this or this or this, but can we just get a blood test that shows either you have a specific risk or a general risk? And so I think if we redo this whole session in 5 years or 20 years, it'd be a whole different conversation, most likely.
Yeah, science keeps evolving. It's
Yeah.
a beauty, right?
Yeah.
I just want to take a few minutes, just looking at the time, just to end on a note of talking about surveillance for a moment. And, thinking about the people who are in that survivorship period of time, how does surveillance get determined for those patients, and who should they be turning towards to get that information?
Yeah, and I'll ask you, I think, so you're talking about surveillance for their particular cancer that they're in the
Correct.
survivorship, right?
Yeah.
So, so there's a number of different ways to do that, and there should be interaction between oncologists and primary care. So it's good that we're both here. So for our patients who finish treatment and they're in a remission, that's when you would be doing surveillance generally. Number one, we have people participate in our survivorship program, our MRW, Myra Rubinstein Weiss Life Survivorship Program. So that specifically entails a structured thing where people have a one-time visit with our nurse practitioner, survivorship nurse practitioner. They go through a document that it summarizes all the treatment that they've had, the details of it, their specific chemotherapy, radiation, surgery. They have their follow-up screening recommendations placed in there. So they actually have a document. It may not be down to the month, but it's the general recommendations of what you're going to have. And then it also has a lot of resources available for patients, Cancer Wellness Center, et cetera, to help people in the survivorship phase. Generally speaking, we're following our patients pretty closely. So at least early on, much of the specific follow-up for cancer screening is being done by the oncologists. As people get farther out, maybe beyond a 5-year point, for example, they may be seeing their oncologist less, or maybe even turning over screening back to their primary care doctor. So that communication is really important. For example, this document that I talked about gets shared with the primary care doctor so that they have it and it's sitting in the chart. But it's very disease dependent. It depends on the specific type of cancer. It depends on the stage. It depends on the risk of reoccurrence. Some people have a very low risk of reoccurrence, in which case the screening for reoccurrence actually may be infrequent. You don't want to put people through extra testing with possible harm from testing, anxiety, false positives, if you're very unlikely to find something. Or you may have somebody who has very high risk of reoccurrence, and then you're going to be seeing them often, screening them often, and that benefit from the screen starts to outweigh the risk. So that's a general statement, but again, it depends on the individual. So as oncologists, we like to stay very, very involved early on so that we could help make those judgments.
Agreed, and I'm always working in that team like fashion with oncology or whoever else may be involved.
Well, and I think it highlights the need, it sounds like there's a system in place for North Shore patients for the oncology department and the family medicine doctors to be interfacing. And if you're not in a healthcare system that has that flow, sounds like the important for patients to be ensuring that there is communication from the oncologist to the family medicine doctor, or that they're at least sharing those medical records or talking to their family medicine doctor to kind of keep them in the loop, because long term, that is who they're going to return to for care. Knock on wood, fingers crossed that they make it past that 5-year mark. That's the person that's going to be watching them longer term.
Agreed. Yeah. Yeah. And even as you point out, without that formal document, you see a patient in the office and then you transmit a note, a communication to the primary care doc to let someone know that, they're doing well and this is the plan, or we've run up against this problem and this is what we're going to do.
Yeah.
And I think it's so helpful just as a reminder to I think sometimes I run into patients who are reluctant to talk to their oncologist or their doctor, talk to the office and say, hey, I need you to do this. But to hear that's an expectation that there should be cross-discipline communication as people are going through the cancer experience, and especially as they're winding into survivorship.
Absolutely. Yeah. And it is not to plug any health system, but I mean, the idea of having a health system and having all your care in one health system that has one medical record, whether it's North Shore Advocate or Northwestern or whatever, that is really helpful because communication when it's simplified, people do it.
That's the benefit. Well, I'm looking at the time and I see we're running at the end of our time. So I just want to thank you both for being here and taking the time to speak with me and to our audience today, our YouTube audience, our Facebook audience. Thank you both for all of your expertise and information here.
You're welcome. Thanks for having us.
Thank you. Thank you for having us.
Yeah, thanks. And I will be back here again on August 11th for our next staff chat, and hope that you will join us again. So thank you all for being with us here today in the Zoom room, on Facebook, or watching this on YouTube. And I'll look forward to seeing you again next time. Thanks, guys.